All right, good afternoon, everyone. We're going to get started. So thank you all for joining us today for the South Texas Regional Family Medicine Grand Rounds. Next slide, please. Thank you in advance for muting your microphone once the presentation begins, being attentive to the presenters and engaging in the session, keeping your camera on when appropriate, registering for CME credit for each session, and completing and submitting a session eval form. Next slide, please. So here's the code for today. If you haven't registered, just text your email address to the number and then text attend 1009-3253. I'll leave this up here for a bit so you can all claim your CME credit. All right, next slide, please. And again, this is just more information how to get that CME credit via text. Next slide, please. And then this is how to get your CME transcripts. Next slide, please. And then this is just information regarding the AAFP credit system. Next slide, please. And these are the core competencies that the grand rounds will address. Next slide, please. Stacy Ogbeide has no financial relationships with ineligible companies to disclose. Next slide, please. And Dr. Nadeau has a brief introduction for us.
Dr. Ogbeide is a board-certified clinical health psychologist. She is the primary care track coordinator for the Clinical Psychology Internship, associate chair for professional development and scholarship for the Department of Family and Community Medicine, and an associate professor on the tenure track of the Department of Family and Community Medicine. Dr. Ogbeide has a joint appointment with the Department of Psychiatry and Behavioral Sciences. Additionally, Dr. Ogbeide serves as an assistant dean for faculty in the Office for Faculty within the Long School of Medicine at UT Health San Antonio. Dr. Ogbeide is now known for her work in behavioral health integration and primary care, serving on committees such as the National Integration Academy Council through the Agency for Healthcare Research and Quality, the Integrated Primary Care Advisory Group through the American Psychological Association, as well as the associate editor for the journal Families, Systems, and Health. Dr. Ogbeide has over 50 scholarly publications and over 160 professional presentations conducted nationally and internationally. Dr. Ogbeide's professional areas of interest include the primary care behavioral health consultation model, behavioral medicine, health psychology, faculty development and mentorship for those who are underrepresented within academic medicine, clinical supervision in primary care workforce development. Dr. Ogbeide's work has been featured on Texas Public Radio and in the San Antonio Express News. So please help me welcome Dr. Ogbeide. She is going to discuss optimizing care for people with opioid use disorder and psychiatric comorbidities, addressing stigma in primary care.
All right, thank you for that, Dr. Nadeau. And good afternoon, everyone, or morning. I guess it depends where you are and when you're watching this. Since we're on Zoom, please use the chat box to throw out questions, throw out comments, your thoughts and free associations, whatever it might be. And I'll make sure to address all the questions before we finish today. But if there's a burning question, I'll pause and address it in the chat box as we go about our time this afternoon. So these are the objectives for the talk today. I'll be talking about stigma and specifically different types of stigma as it relates specifically to people with opioid use disorder and co-occurring psychiatric conditions, talking about the presentation and what this looks like, and then of course addressing some anti-stigma approaches for primary care and healthcare settings in general. So my hope is that we will cover all of this well. So I have a quote that I wanted to start with from an author that I enjoy. People who know me know I like to read both fiction and nonfiction. So this is C.S. Lewis. He's written great work, and this is one of the quotes that I appreciate that he talks about related to stigma and behavioral health issues. So he says mental pain is less dramatic than physical pain, but it is more common and also more hard to bear. The frequent attempt to conceal mental pain increases the burden. It's easier to say my tooth is aching than to say my heart is broken. And if you've worked with patients at any capacity, you probably have seen this in different ways where patients will come in and tell you, my stomach hurts or my head hurts. And you order all the tests and everything and it comes back negative, and then later on you may find out they had a loved one pass away, or they're going through a divorce, or they're going through some significant change or trauma that it's just easier to say, at least in our culture, I physically hurt than to say I'm going through some type of emotional pain. So hold on to this quote as we go about the information today, and hopefully talk about ways to address this. So let's talk a little bit about stigma, and just in behavioral health in general. Some of the things that unfortunately lead to poor health outcomes is just the impact of stigma. And so what we do know is that about more than half of the people who do have a behavioral health issue, and typically when we say behavioral health issue, I'm talking about something that meets DSM-5 criteria. Over half of them don't get help for their situation, for their disorders, for their condition. We have documented evidence that people avoid or delay treatment due to lots of fears, losing their job, what people may think, what their family might think, what if my employer finds out, if you're in healthcare, do I have to report this to the state board? Okay, if I have to do that, then I'm not going to do it. I'm not going to go get care. So there's lots of these contextual factors that unfortunately impact someone's ability to go get help, behavioral health help. And because of this too, because of the stigma, we still very much have prejudice and discrimination against those who have behavioral health issues. I was talking to someone, I think I was talking to a student in clinic on just a few days ago, and we were talking about the heaviness of what it means when a patient has something like borderline personality disorder in their medical record and their problem list, and what biases come up for healthcare providers when they see that. If the patient goes to the emergency room, the immediate biases that may pop up in terms of how that patient may be treated just from what's listed in their chart. And so being mindful of that. So all of these things play into someone's access to care. There was a study that was, studies that have been done, but a policy paper that was put out fairly recently in the past couple of years that has also documented stigma as a fundamental hindrance, particularly in the US for people seeking treatment for opioid use disorder. And it's pretty significant because of the piece that I have there down at the bottom of the screen that talks about, yes, we know many drugs contribute to overdose, but opioids accounted for almost 3/4 of overdoses in the peak of the pandemic. And so this is a problem. This is a big problem nationally. If we know this is an issue, and we have great treatments, we have evidence-based treatments that can help greatly, but stigma is the big barrier or roadblock for people getting treatments. And so I'm going to dig into that a bit more. But on this next slide, I would love for you to just type in the chat box what you feel, or what the factors you feel are that impact stigma. What plays into this? I've given you a few hints over the past few slides about what may play into this, but I'd love to hear your own anecdotes or your own experiences with patients or family members. This can also impact us personally, not just in the clinic setting. But let me pull up the chat box to see if we have anything. I'll give folks a little bit to think about factors that you feel impact stigma. So I'm seeing culture, absolutely, culture is popping up a few times here. Race, ethnicity, absolutely, that impacts it. Gender impacts it. Just how we speak about it. Someone said dialogue about the conditions. I was speaking at a maternal health conference focused on substance use disorders of people, of birthing people, and I was giving the workshop, and these were all clinicians who specifically work with those who have substance use disorders, and the stigmatizing language that was coming out of some of the clinicians' mouths in terms of calling people addicts, and really them having a misunderstanding of how substance use disorders show up, and just how you treat those was interesting, because this is who we're supposedly putting our patients in to get care from. So we are very guilty of this too, how we dialogue as clinicians about people with substance use disorders. I see religious beliefs in the chat box, misinformation, yeah, thank you, about substance use, not adherence, patients not understanding that it is a disease. I see, like, seeing it as I just need to try really hard, and I won't have this. You don't necessarily hear that a lot about someone who has hypertension or diabetes. I just need to try really hard and I won't have that hypertension anymore. But we hear it quite often with substance use and psychiatric conditions. Historical context, yeah, thank you for the feedback in the chat box. So I want to go into some different types of stigma. Again, a lot of these things you all have talked about already in the chat box, which is fantastic. But there's 3 types of stigma that I want to dig into that contribute to barriers to care, access to care. One is, again, just the public, what you all said, culture, how culture views psychiatric conditions, substance use, many times in a negative way. I think, and I talk about this often, that if there's one thing that COVID did well, COVID did many things poorly, but one thing COVID did well was it got us as a culture to talk about this behavioral health more broadly, in more positive ways, encouraging people to get help, making it supposedly easier to access through things like telehealth platforms. And you see companies like the Better Health commercials that are out, or other telehealth companies that are trying to open the conversation in a more positive way than typically what it's been is more negative. Then you have self-stigma, which again, you all put that in the chat box, which is great. And so this is someone's negative attitudes about having a substance use disorder or a psychiatric condition. This could be internalized shame. So feeling like something's inherently wrong with the person for having said condition. And so therefore, because of your own negative attitudes, that person doesn't seek treatment for these things. And then we have the structural stigma. And so these are the big system pieces that contribute to people getting access to care. And so this could involve policies, both system-wide policies in your health system. It could be policies at the state level, regional level, national, federal level. I have some examples here. Lower funding for behavioral health research. That's one example of structural stigma, as well as just many health systems not having behavioral health options available, period, still, or having very few, where you'll have this huge health system that may have 200 family physicians, but have 5 behavioral health clinicians. It doesn't make sense. And a lot of that is because of structural stigma. Another piece that I don't have listed here is reimbursement rates for behavioral health services are much lower compared to reimbursement rates for physical health conditions, for example, or even comparing the surgical reimbursement versus what we call the cognitive disciplines, the advice-giving disciplines. Primary care is included in that too. And so those are all examples of structural stigma, how the system is not helping people also get access to care. So the impact, as you can imagine, if you are a person or you are a provider trying to care for patients who are experiencing these co-occurring conditions, reduced hope. Am I ever going to get better? Is my patient ever going to get a phone call to schedule that initial appointment? Is this ever going to happen? Lower self-esteem, increasing in symptoms, of course. The longer, we have data that shows the longer people go without care, the more debilitating the conditions become, and the more debilitating it becomes, it can get even harder. We're just in this cyclical process. As you can imagine, difficulties with social relationships, reducing the likelihood of staying in treatment once they finally get access to treatment. The likelihood of staying in treatment reduces the longer it takes to get there. So again, it's just really horrible cycle that people get stuck in. More difficulties at work. So a lot of healthcare organizations, non-healthcare organizations, just in general, employment settings offer something called employee assistance programming. We offer that at our institution. University Health offers that for their employees. But what we find is only about 3 to 5% of employees utilize the EAP. So again, a lot of that goes back to stigma. Will my boss find out? Will my employer, my supervisor find out that I went and got help? They cannot, but again, the power of our thoughts can definitely impact the behaviors that we choose to engage in. Poor recovery, as I mentioned, health insurance just not covering things at all or making it even more difficult. We had the Mental Health Parity Act was passed in 2008. And so if you're familiar or you remember, I remember that act very vividly because it impacts what I do day to day as a clinician. But what it was supposed to do was supposed to give equity to both behavioral health and physical health conditions, where insurance companies could not say, we'll cover physical, but we're not going to cover the behavioral piece. The other piece that it did is got rid of the need to have a referral. And so if you wanted to go find a psychologist or a psychiatrist to go see on your own, you don't have to have your PCP re-refer, you can just go directly there. And so it was there to, again, give priority to both physical and mental health, substance use, behavioral health issues, and improve access to care. I'd say for the most part, it did do that, but we still have insurance companies to this day still having barriers up saying, well, we need a referral first and we need this. And so there's still a lot of re-education. 10 plus years later, we actually just had a situation that happened this week or last week in clinic where we had a similar situation happen very recently. So again, a lot of that re-education has to take place, but again, that's an example of the impact of stigma and discrimination. And so a lot of these things you all mentioned a little bit ago, which is great. So again, in primary care, a lot of this also shows up in primary care, as you can imagine. We are the #1 place where patients with behavioral health conditions come. More patients come to primary care compared to specialty mental health care for psychiatric, psychological services. And I don't see that number changing anytime soon. So we are it. This is where patients come for everything. And so as you can imagine, this will impact our attitudes of how we treat our patients, giving them access to behavioral health services, picking and choosing who gets it, who doesn't. These are all pieces of the puzzle that go into stigma. Lack of awareness from the clinician standpoint, pessimism towards the recovery process. And so how you view the recovery process, or even if you even feel recovery is possible as a clinician, that impacts the ability of what you offer, what you don't offer to your patients. If you think recovery is not possible, the likelihood of you putting those referrals in are lower, just from what we find from the evidence. And so, and pieces of that too go into lack of thinking, I need these skills to help my patients. This is not my problem. They're not going to get better anyway. Why should I bother? All of those things play into access to care in the primary care setting. So who are our patients? These are our patients. So my hope is that, again, this is to shed light. A lot of these numbers might be unfortunate to see, but this is the reality of what people think about individuals with opioid use disorders and co-occurring psychiatric conditions. So many Americans, again, this is just based in the US, view poor individual choices and a lack of discipline as the cause of why people develop opioid use disorders. You and I know, hopefully, that is not the case, but this is what people think. And so as you can imagine, how people may then go about their day or how they may treat people who have opioid use disorders if this is how people view, well, you just didn't try hard enough. If you just try harder, you wouldn't have this. Again, we don't necessarily do this with physical health conditions, but we're really quick to do that with behavioral health conditions with patients. 78% of Americans believe people who are addicted to prescription opioids are themselves to blame for this. So again, putting it very much self-focused. It's your problem. If you would just do X, Y, and Z, you wouldn't have this issue. You are at fault for this. 72%, again, people believe it's linked to a lack of discipline. And then I think one of the most interesting pieces here is this last bullet point, where there's a national sample done where they found that higher stigma was positively correlated with greater support for arresting and prosecuting individuals who obtain opioid prescriptions from different doctors. So again, just kind of let that sit in and just think about how we view people with opioid use disorder. This is what we think. This is what we think, and of course, what we think can definitely impact what we do or don't do when they're in our care. Some other numbers for you. Again, 16% of people are willing to have a person using opioids to marry in their family. So if you flip that, 84% of folks would not be willing to have someone with an opioid use disorder be married into their family. 28% of people are willing to have a person using opioids work with them at their job. 27% of people think, I think this is probably the most, they're all difficult to see, but I think this is probably the most difficult one to see. Think that people with opioid use disorder are essentially deserving of care. And then 10% people think that people with opioid use disorders are strong. So again, 90% view them as weak. So let that sit in. Thinking about your patients with opioid use disorders, co-occurring disorders, thinking about one of the big pieces that helps people with recovery is social support. But if this is the social support people are getting, as you can imagine, the recovery process it's already rocky in and of itself when you have good social support. But if this is the viewpoint of people in their lives, you can imagine how difficult and how isolating this process of recovery could be for patients with these conditions. So last slide about the sad numbers here on the screen. 49% of people believe that there's an effective long-term treatment for OUD, which is interesting because we do have effective treatment. So almost half of people don't realize we have effective treatment. So that could be its own talk in and of itself in terms of public health campaigns to let people know we have treatments that work, and here's how you can get it. Here's how you can get access to it. Primary care is a gateway for you to come in and get access to this. But if you don't know that there are treatments available, you might fall into that category that is prolonging treatment or never getting treatment in the first place. So again, what can help? So I wanted to at least kind of map out the views of what people, this is where we are as a society, as a group, about how we view this, how stigma is playing into this. And so what we can do, there are things that we can do. So I'm going to break it down on different levels of things that each of you can do individually, what you can do in your health systems, in your clinics, if you teach with your students, whoever your population is that you are working with, there are things that you can do. So this screen is probably super tiny as I'm looking at it now, but I really love this. This is from Cheatham and colleagues, and they did this really beautiful article where they looked at stigma from 3 levels. They looked at it at a micro level, what you would do face-to-face with, if you see patients, what you would do in the exam room. They looked at it at a meso level, so educating the public, educating clinicians, students within the health system that you work in, and then the macro level, which is just how we fund research, how do we pay for this, reimbursement policies, things like that. And they have specific strategies that they talk about. So I'm going to go through these strategies more so on the micro and meso level, because those are pieces that you all can immediately take back with you and put into practice in your face-to-face patient encounters. Or if you are in a position to do something at the meso level in your healthcare system, I would encourage you to think about these things that you could potentially do. So what can help? We call them anti-stigma interventions. And so I'm going to go through some things at the community level that you can do. Community, again, that micro and meso level things that you can do. One of the big things that I bolded here that's recommended is including contact. So someone with lived experience can make a huge difference when you're doing any type of educational campaigns, trainings. If any of you are involved in teaching of any type of learners, including someone who's with lived experience is a great way to do this. Earlier this spring, we had Dr. Bone, one of our addiction medicine physicians, give a grand rounds related to the topic of opioid use disorder and pain, chronic pain management. And if I'm remembering correctly, if someone in the chat box can correct me if I'm totally thinking of something else, he had a person with lived experience join him for his talk, which I think was a beautiful example of what this is. So that's an example of that. And so again, think about the spaces that you inhabit and getting permission from someone with lived experience that's willing to share their story, I think is powerful. And that's a great way to reduce stigma related to it. When people can put it to a face, especially a face that is in their realm, it makes it more real for people that this is happening in your backyard, whether you realize it or not. And so this can really help bring it down to earth for people. Focusing on a range of disorders, again, we're talking about the data around people with opioid use disorder, but you can do this with a variety of behavioral health issues too, depending on what platform that you have. Stigma, again, I was focusing on stigma with co-occurring conditions. Stigma with behavioral health is ever present. And so you could use this with any presenting condition that you feel is appropriate to do. And then the other piece here, I already talked about people with lived experience, emphasizing societal versus individual causes of the addiction process. Again, we have clinicians who misunderstand the process of addiction. And so the more that you can give education to the community, your patients that you serve, if you're working with a patient who has a comorbid substance use disorder, I'm spending time in your visit just to discuss, well, what does this mean? Does it mean I failed? I will tell you this, there is a lot of shame around when folks who are presenting with substance use disorders, whether they tell you or not, the likelihood of them telling you is probably quite low. But just know that there's a good likelihood that it is there. And so having these discussions with your patients, carving out a visit just to talk about this, I promise you will mean and carry a lot of weight for the patients that you're serving. And then being mindful of the type of narrative that you're attaching to it. If you're doing some type of community level, doing something at a community event, having a panel presentation, for students, for learners, whatever that might be. Just being mindful of the narrative and the word choice that you're using. I believe I have a slide later on that will talk about using person first language as an example of this. So not an addict or not a diabetic, but a person with fill in the blank, person with, they are not their condition. And so just be mindful. I hear it all the time when I'm in clinic, and I heard it quite a bit at that conference I was at. And so being mindful of this, that person first language is the preferred terminology to use when describing a person with a health condition. So other things that you can do. Targeting groups that have the most interaction or where there's a lack of help-seeking behavior. So you would know this. I hope you would know this. If you don't, just ask in wherever you practice, especially if you're not here at the Family Medicine residency. I know we have folks that are at other places. Your clinic team may have this data already, but who is a group that you all are missing? Is it young? Is it the AYA group? Is it the 18 to 29 range? Are those folks being missed in your population? Is it undocumented communities? Is it military communities? Who is it that help seeking is not present, or you find these folks just are not coming into the clinic and getting out of the clinic walls to do interventions, whether it's health fairs. I know we do a lot of health fairs. Oh, someone says they lost sound. Can people still hear me?
Yes.
Yes.
Oh, okay. All right. Whoever lost sound, sorry. I don't know what happened, but everyone else can hear me. All right. So whether that's a health fair, whether that is a public health event, whatever that might be, is targeting people who are being missed, who are not coming in for help. When you know that there are pieces to the puzzle there that are being missed. Again, being mindful of the language that you use, being specific to the cultural of the target group. One example I have of this is one of the terms that we use to describe behavioral health providers, clinicians in the primary care setting. We use the term BHC, or behavioral health consultant. We're consultants to the primary care team members. And I have a colleague who practices also as a BHC, but they practice down in the Valley and the RGV area, for those who aren't familiar, in South Texas, in the McAllen, Harlingen, that area down there. And what he found was that the term BHC didn't click or connect with the patients coming into their primary care clinic. So they actually used the term, it's going to leave me now that I'm talking about this, but they use something similar to a health coach to describe the behavioral health consultant, because it just means more to the patients there, and it helps reduce stigma for the patients to actually come in. This person's going to help me improve my health. They just said health is health, whether behavioral health, physical, it's your health. And this person's going to coach you with whatever health needs that you have going on right now. And they found that helped reduce stigma, increase access for their patient population. So that's an example of how to tailor language that's focused on having anti-stigma attached to it. Emphasizing that we do have effective treatments. I think those of you who are clinicians in the room, anything that you can do to be a broken record to the patients and families that you serve, to let them know we have treatments. We have treatments that work. I always am mindful of the terminology. So I tell patients, rather than saying we have evidence-based treatments, people are like, I don't know what that means. I say we have treatments that we know work really well. They work really, really well for your condition, for your health conditions. And so the more that you can push that, whether it's again, face-to-face or at a health fair, if that's where the platform that you have, the emphasis of that is of importance, because again, we still have about 50% of Americans thinking we don't have effective treatments to treat opioid use disorder. The last piece here that's recommended is avoiding messages that are not effective at reducing stigma. So it was interesting for the longest time in the substance use world, there was an overemphasis on framing substance use disorders as being biologically based only, really leaving out the context of the social aspects of it, how stigma plays into it, the psychological aspects of the addiction process, and just really hyper focusing on the biological piece. What they found over time, now that there's been enough years to collect data, is that has not been shown to reduce stigma. What has been shown to reduce stigma is that really that biopsychosocial approach, that there is the biological piece and there's psychological piece, there's the social piece, there's all these other pieces that impact the development of a substance use disorder. Looking at it holistically is found to be more successful at reducing stigma than solely focusing on the biomedical piece of the addiction process. So something interesting, something fairly new, that's a recent change in how we talk about the development of disorders with patients. So some things to do, again, a lot of this can be done at the community level and face-to-face too. You can use them interchangeably. Talk openly. I know a lot of you, I know a lot of you because I practice with a lot of you on the screen. I know a lot of you do this. I don't know if everybody does, but I know a lot of you do, where normalizing conversations about behavioral health. Normalize this with your patients. Still to this day, I still have patients that like, I don't want to talk to a shrink. I'm not crazy. That language still pops up even in 2024, even with all the great work COVID has done to talk about behavioral health. We still have patients that are like, no, even though they desperately need help, they are refusing help because of self-stigma. That, no, I'm not crazy, I don't need it, I'm fine. And so anything that we can do to normalize it is helpful. I think what has helped too is just the mandated screenings that we do now for depression and now anxiety and intimate partner violence. We're asking about substance use, tobacco use, alcohol use, other substances. We're asking those questions at the beginning of every primary care visit. So some of that can help, but the follow-up piece is then if someone does screen positive, normalize the conversation about it during your visits, talking about that this is part of health. This will improve your overall health if we get taken care of, just like we're going to take care of your diabetes. This is another piece of your health picture that we want to address as well. Continuing to educate yourself. The fact that you're here in this grand round is showing that you're doing what you need to do to respond, to address any of your own misperceptions, we all have biases. If you have a pulse, you have biases. Whether you want to realize it or not, we all carry them. And so if we can at least bring the biases to the light and do something about it, that's a step in a great direction. So just the fact that you're continuing to educate yourself about this, how you share information with patients and families that you serve is huge. I talked about this a few slides before, but I'll highlight it again, which is the importance of person-first language. Just reminding people that words do matter. How you describe someone could make or break their willingness to seek treatment. Because people can internalize how you describe it as, oh, okay, well, they think, well, people with the psychiatric condition are broken or don't function well in some way, so that I'm not gonna, no, I'm fine, I don't need anything. Just based on what we say in the visit. So again, be mindful of that, and please use person-first language when talking about people. And then, of course, I can't leave this slide without talking about the equality between physical and behavioral health conditions. Anything that you can do to draw comparisons of that in your visit, please do that. If you had cancer, we wouldn't hopefully deny you treatment. If you have diabetes, we're writing a script and sending you to the dietitian and sending you to we're doing all these things that should be happening for someone with an opioid use disorder, someone with anxiety, someone with depression. That same thing should be happening. And so anything that you can do to bring that to the light with the patients and families that you serve would be highly, highly encouraged. And of course, show compassion. This is tough. This is really tough for people to talk about because there's so much weight, stigma, shame, all of it that's attached to having a co-occurring substance use disorder and a psychiatric condition, plus maybe other conditions that the person presents with. So showing compassion can go a very, very, even if you have no idea what to do in the visit, if you feel stuck, this person just shared all of these things with me, I didn't know this was going on. Showing compassion, thanking them for sharing that with you, for trusting you in that moment to share it goes a very long way. I kind of hinted on this a little bit before, but being honest about treatment, normalizing it, just like any other care treatment. Sometimes if the behavioral health person is available, you can bring them into your visit just to kind of do the live warm handoff, just to introduce the person to the behavioral health person, just to let them know this, they don't have 5 ears, they don't have, horns, they're just a normal person here to just take care of your needs. I don't know if Dr. Lawler is here on the thing, I'm not sure. But Dr. Lawler was very famous. He's one of our retired family medicine physician faculty. He would do that with me particularly all the time, where he would just say, can you just come in with me? I just want to introduce the patient. They're a little nervous. They've never met with a behavioral health consultant before. So I would just go in with him and introduce myself with him, and that would start the conversation going. So that's something that to help normalize it for your patients, that this is part of your care. Just like you might bring in the pharmacist to the visit, you can do that as well with behavioral health. I'm jumping around a little bit here. The last piece here, professional self-disclosure. I always say when appropriate, when necessary. Many times it may not be necessary, but sometimes it might be necessary. And so you don't need to tell the patient your deep, dark secrets. We're not asking you to do that. But sharing that, I've had some tough times where I sought help too, and it really helped me. And so I would love for you to consider meeting with a psychiatrist, meeting with a psychologist, meeting with whoever you're wanting them, the substance use counselor, whoever it might be. Especially if this is a patient that you've known for a long time, you have really good rapport with them. Maybe not at a new patient visit yet, but if you've known them for years and the trust is there, it might be appropriate. That might be what they need to hear, especially if they trust you so much. They might say, well, goodness, if my PCP is willing to share that with me, I can at least try that and see how the visit goes for me. This next slide here are just essentially things of what we would not encourage you to say during a visit. And so if you have said these things, that's all right. This is great. We're gonna show grace to each of us here in the room, where you can at least say, okay, now I know, now I can do better next time. So things like, it could be worse. Just deal with it. Snap out of it. Well, everyone feels that way sometimes. You may have brought this to yourself. We've all been there. Just pull yourself up from your bootstraps. You can do it. Maybe try thinking happier thoughts. These are all comments pulled from qualitative interviews between a clinician and a patient during an encounter. So these things have been said. You may have watched a visit where this has been said. So what we know is these things do not encourage and actually increase stigma and increase the likelihood of someone not going into treatment. So instead, we would love for you to think about things like this. Thank you. That's probably my favorite thing to say is thank you for opening up to me. Thank you for sharing that with me. You didn't have to share that with me, but you did. And thank you for being willing to share that with me. Is there anything that I can do to help? Sometimes patients don't need the referral right now. The fact that they shared that with you, they could have been your patient for 5 years. We actually had this happen where a patient was following up for 5+ years, and whatever year 6, day 1, whatever had her be willing to share, she opened up. She said that she's been using cocaine for this many years, and I didn't want to share this. I thought you all would fire me. I was so ashamed. She just started opening up to me and the PCP in the visit together. And all we did was, is there anything that we could do to help at this point? Is there anything that you feel you would need right now? And at that visit, she said, I just wanted to just share it first. We said, okay. The next visit, we talked about, is there anything that you would need at this time? And then she said, well, maybe some help, maybe some professional help. And then I was able to then take over and provide her with that help. So sometimes people just want to be heard. That is the intervention in and of itself. If you're familiar with Dr. Vincent Folletti, he was the preventive medicine physician behind the big adverse childhood experiences research study that took place in Kaiser back in the early 90s. When he collected that data over the years about all of these really traumatic experiences that people went through in their childhood, and he was asking them during your visits now as an adult, when you see your primary care provider, what would you want them to do? And almost all of the patients said, I just want to be heard. I didn't want a referral at that point. If they said maybe later I would want a referral, but not this moment. I just want you to hear me and see that this is a part of me, but doesn't define who I am. So listening can go a very long way in your visits. I'm sorry to hear that. It must be tough. I'm here for you. I can't imagine what you're going through. People do get better, and still hope. Again, a lot of people, from what we saw in the early slides, feel like this is a death sentence. There's no treatment. I can't get better. I might as well just not try. Letting them know that people do get better. We do have treatment. How are you feeling today? I care for you. Those are things that usually are said by a family member, not a clinician, if you can figure that part out. But these are just some ways to, again, engage patients in conversation, patients and families in conversations, to hopefully decrease stigma and give people access to the care that they deserve. So I do have a few more slides, but I want to pause for a moment because I gave you a lot of information. And so I want to see if people have questions. You are welcome to type your question in the chat box. If you're in a place where you can unmute, you're welcome to unmute and ask your question as well. I see in the chat box, Dr. Lawler was the founding program director for our program. He sure was. Yes. Thank you for that. Questions people have. I'll pause for a little bit. No questions? I know I wasn't that crystal clear. All right, well, I have a few more slides left in the deck that I'm gonna go through. But if you think of something, just throw it in the chat box and I'll do my best to pay attention to that before we wrap up today. So if you remember nothing else from the past 45 minutes, just remember these things, that number one, language matters. How we word things in our visits related to people with opioid use disorders, psychiatric conditions, it matters in terms of how they view themselves and their willingness or even wanting to hear you out to talk about treatment options. System change is great for those of you who are systems warriors. If you want to change and give more provider trainings in your health system, you want to fight policy and get better reimbursement rates, please, we need you. And what you do in the exam room also matters. So please don't think, well, I don't go to Austin to advocate for reimbursement changes, but you see patients, or you work with students, or you work with residents, or you work with another human. So what you do in your spaces, I'll say that, not even if you're not a clinician, what you do in your space still matters. So just keep that in mind. And then start the conversation. I assure you, someone is waiting to talk to you. So please open the door, even if it's a colleague. You don't have to be their clinician, but you can be a listening ear and then point them in, the direction of, here's a place where you can get care. If and when you decide to do that, here's a place where you could go. So start the conversation. Someone is waiting to talk to you. Here are some resources to consider. These are all anti-stigma organizations. that focus on clinician education, focus on just public education to reduce stigma. So if this is something that piques your interest, or you want to dig into more, or if you work with a particular patient population that has a lot of stigma related to opioid use disorder, related to psychiatric conditions, that you're thinking, what could I do outside of the clinic walls to help this population? These are groups that you could potentially connect with and have great online resources to see what you could use to help with that. Other things that you can do, the CDC has fantastic resources, and there's some guiding principles to reduce stigma as well, specifically stigma with opioid use disorder. So a lot of what I discussed today, you can find that nicely consolidated on the website to help with having these conversations in the areas that you all inhabit. These are two books that are fantastic. I don't know if anybody's read Raising Lazarus or Drug Dealer MD. If you have, let us know in the chat box. You can give your thoughts about these books. Beth Macy is a journalist, and I read this book, I think last year, and fantastic view, specifically on the opioid use disorder, the opioid pandemic in the US, where she goes through different parts of the country and interviews families and how the opioid use disorder has impacted the family structure, how it's impacted stigma, how stigma has impacted, I should say, access to care, access to treatment. So beautiful book, sobering with some of the information there. There is a shout out to some of the research being done with substance use disorders here at UT Health San Antonio in that book. And it's an audio book. If you don't like reading hard papers, you can find it on the audio piece. The Drug Dealer MD by Dr. Lemke. She was at Stanford. She's an addiction medicine physician. I don't know if she's still there, but she actually came to UTESCA pre-COVID and gave a fantastic lecture on this book, talking about how physicians, clinicians, their role in opioid use disorders in terms of care, access to care, the type of care people are getting. So also very sobering, but she's very honest in the book of things that we could do better as clinicians and how we treat patients with opioid use disorder. You could probably find that talk online if you want a Reader's Digest version of the book. You can find her one, it's like an hour-and-a-half lecture that was done, but it was fantastic. And so these are some resources if you're wanting to dig in more to this topic that I would encourage you to look at. I do see a question in the chat box. It says, what would be the time frame that physicians would address these types of situations with patients? Sometimes it may take more. Yeah, it would take more than 20 minutes, possibly. So one of the lovely things, I'm assuming you're in primary care. If you're not, let me know. In primary care, you do have the luxury of having that longitudinal follow-up. And so just like when you're working with someone with uncontrolled diabetes, you wouldn't quote unquote fix that in one visit. You'd bring them back for closer follow-up. You do a lot of shaping, you do a lot of adjustments, you do a lot of conversation, you do a lot of getting their support. It'd be in multiple steps. You would do essentially a very similar thing for someone presenting with a co-occurring disorder, like an opioid use disorder and a psychiatric condition. So I wouldn't necessarily hyper-focus too much on the time, but focusing more on the longitudinal piece, that this is something that will probably need to happen on more than one occasion. And if you have if you're fortunate to have other team members like behavioral health or a pharmacist on your team, you may need to, with the patient's permission, bring in help to take this as more of a team effort. So it's not yet, but I do volunteer in free clinics. Yeah, so free clinics might be a little bit more difficult because you may not have the longitudinal piece there. But if you do, lean on that to help you with this process, lean on that longitudinal piece. But I always also say, if you have that one shot with someone, do the best you can with that one moment and trust that someone else will pick up where you left off at a different clinic, at a different location, at a different time period, that we may not be the ones to quote unquote treat the issue completely, but we can at least be a part of that patient's story. Someone else will pick it up where you left off. But thank you for that question. Any other questions before we wrap up today? You are very welcome. You're very, very welcome. Well, I know we have about 5 minutes left, so I just want to say thank you all for your time, for your willingness to type in the chat box. I appreciate that. If you do have questions and you didn't want to ask it in front of people on Zoom or the recording, you're welcome to email me offline. I'm happy to answer any questions people have. Thank you so much.